to retain it and to apply it when needed. May your name be glorified. In Jesus' name we pray.
Amen.
Okay.
By the grace of God, next month in Burundi missions will be having a special program, understanding the times. So, there's one Christian movie producer that will be coming. We are working on it. Just want to invite you if you'll be free. I'll send you the link, and it's an eternity. Okay, sir.
Oh, that's another time.
Sir.
I said just let me know on time.
Okay, sir. Once the poster is ready, I'll let you know. Okay, sir.
It's okay.
So good.
All
Let's
right.
continue. So we stopped yesterday. We stopped here. So let's start with verse number 5. So what did you define as positive estrogen receptor?
Okay. Positive estrogen receptor is 1%, greater than 1% of cells. 1% or more nuclear staining. Define positive ER or PR status.
Yes, positively. So 1% of cells. Okay, good. Number 6, HER2 by fish is considered amplified. What's the criteria for calling HER2 by fish amplified? What's the criteria?
These are two suggestions, something that okay. That should be B.
What is it? Without looking at the options.
Okay. Copy number greater or equal to 4 and ratio greater or equal to 2. I've looked at the option, but I remember the copy number essentially.
The copy number, the two copy number should be greater than or equal to 4, and the HER2 17 ratio should be greater than or equal to 2. Both criteria must be fulfilled for you to call it amplified. If there's discordance, then it's not amplified. If both of them are low, then it's unamplified. Number 27, HER2 immunohistochemistry 2 plus is considered what?
Equivocal. Or what do they call it? It's 2 plus equivocal. Or what do they call it? Yeah, it's equivocal. Then you need to do fish. Continue. Let's continue.
It's family way to taste food.
Okay. Thank you. Good afternoon, morning.
You should come and see the weather and it's going outside.
Close the door. Close the door.
No problem.
I rush to go and catch him. Now, so equivocal fish for HER2 is characterized by what? If you do fish and you equivocal fish,
That
equivocal.
would be like weak. Sorry, it's greater than 10% of cell,
No,
but is
that is for immunohistochemistry. I say fish.
okay for fish. Equivocal, right?
Yes. What do you mean by equivocal?
I can't remember that.
What is the standard fish protocol to say that HER2 is amplified?
Okay, that should be greater than the ratio should be greater than 2 and copy number greater than 4.
Not greater than or equal to.
Or greater or equal to, yes. If you have one of it, Abi.
If you have one
Okay,
of
so
that meets the criteria, that doesn't meet the criteria, that's equivocal. If both of them fail to meet the criteria, that's unamplified. If both of them meet the criteria, then amplified.
But if one of them,
that's equivocal.
okay, that's fine.
That means even fish couldn't determine. Okay. According to ASCO and CAP 2018-14, 2018, focus update. And equivocal HER2 fish result with IHC 0. The IHC came out 0 or 1 plus, or okay. Do you understand question number 9?
It's not clear.
According to the clinical protocol, first of all, let me ask you, when do you send for fish?
When the IHC is equivocal, when it's 2 plus. When the IHC is 2 plus.
Then what if the fish comes back equivocal? What's the answer?
If the fish come back equivocal after you have done you do the IHC first, right? And
Yes,
then the fish now come back equivocal. Then you conclude that the IHC is negative.
you conclude that the HER2 is negative. That's not what
The
captures.
IHC is negative, yes. Yeah.
Yes. If it's equivocal, you shouldn't be saying equivocal again after fish. If fish comes back equivocal,
Mm.
then negative. But if fish comes back, copy number greater than or equal to 4, HER2
Uh,
step 17 ratio greater than or equal to 2, what's that?
is amplified. R2 is
Amplified.
amplified.
Yes. Negative HER2 by immunohistochemistry is defined as what?
It's defined as anything. Okay, 1 plus 0 or 0.
1 or 0. Those
Yeah.
are negative.
1 plus or 0. 0
Yeah.
or 1 plus.
Do you send for fish for those?
No, no.
Not even send for fish. But if for any reason anybody sends for fish and it comes back equivocal, it's still negative. Now, question number 11. In HER2 testing, the tumor should show staining in what pattern to be considered positive?
In
What
R2
pattern is positive?
testing.
Hmm?
In R2 testing, since we say staining is actually uniform intense membrane staining.
Complete membrane staining that is dense, that is strong, in greater than 10%. You didn't add that. HER2 testing validation in each laboratory must achieve what? How does CAP validate whether your IHC is correct or not?
90% concordance with
Of
fish.
IHC fish. That means all your positives must be concordant with what? 90% of the fish. You know, sometimes they may have this, they may decide to go and verify it with fish. And you should have up to 90% concordance with fish for your laboratory to be validated to do testing for this. If you have a lot of 3 pluses, out of all your 3 pluses, only 10 are positive in fish. Then there's a problem with your IHC staining.
OER and PR, an acceptable fixation duration is 6 to 72 hours.
Yes, question number 14.
Less than 6 hours, loss of antigenicity, right?
Yes,
Then greater than 72, masking of antigen.
yes, because of cross-linking of proteins. Number 14.
Which analytical factor affect the level of estrogen receptor testing? Okay.
Not sure. Let's
Validate everybody's community.
look it up.
Okay, we can clarify the use of validate antibody clones.
So, immune receptor testing is commonly used in breast cancer to determine if tumors are responsive to hormone therapy. This test is done with IHC, which involves antibodies that bind to estrogen receptors in tumor cells. Three concepts: analytic factors versus pre-analytic and post-analytic factors. What are analytic factors in laboratory testing?
The testing process, the actual testing process,
Yes, pre-analytic,
before the work, tissue handling,
surgical technique.
interpretation, and reporting.
That interpretation and reporting is post-analytical.
Mm.
Can you give me an example of post-analytical? Somebody may,
Interpretation and reporting.
yeah. So the question is, explain which analytical factor affects the reliability of estrogen receptor testing.
Use of antibody clones.
Yes, because surgical is an analytical factor. So that,
Because you use the
let's give an analytical factor. Out of all this, surgical technique is pre-analytical. The antibody clones that are used, validated on this are analytical factor. Some of the location is like pre-analytical factor. But the precise status, I don't know what that where that falls.
it's still pre-analytical.
So during the analytic phase of ER testing, antibodies are used to detect the estrogen receptors. These antibodies must be validated, meaning that they are used tested for accuracy, sensitivity, and specificity. Using non-validated or poor quality clones can lead to false positives or false negatives, making the test unreliable. That is non-validated or poor quality clones. So you must use validated clones. Therefore, validated antibody clones are critical to the reliability and reproducibility of the test. Surgical test is a pre-analytical factor. Tumor location, this could affect sampling, but not the analytical performance of the ER. It can reflect hormone levels, but it has no effect on the reliability of the test. So they're actually testing. So we like to know our understanding of factors that affect testing. And okay. Which result is considered negative for HER2 by fish?
Is C.
See, perfect.
Ratio less than 2, copy level and not power 4.
Very good.
D is equivocal. Then A and B are positive.
B,
A and B are
right.
amplified.
Yeah. A is not amplified. Why?
Okay, the second one, but the issue is they should actually put the two figure. So, but we don't know. So in this case, we can just say maybe equivocal. But ideally, this is not valid.
It is invalid because to report HER2 by fish, you have to have HER2 CEP17 ratio and not all HER2 what?
Copy number.
Number. So this A and B, they're not serious. Now we are back to this question now. So what is this?
Which one of the relative risk of the one? Can we have something? Is okay. This is where Dr. Apaplasia, huh?
Eh?
Usual Dr. Apaplasia.
No.
Usual Dr. Apaplasia.
UDH.
So
UDH.
what do you think it is?
I'll call this popularly DCIS. Actually, yeah, this looks more like UDH anyway, because you see, it has this circles. How do I put it now? This punched out species
Left,
at the
left. They are towards the periphery.
yes, and there's Roman bridging. So this is UDH. So I'll choose A as my answer.
Maybe it is UDH, then it's going to be A.
Yeah,
But if it is ADH, what will it be?
ADH. I can't remember. ADH has to be like
4 to 5.
4 to 5. Yes, 4 to 5. 8 to 10 is 8 to 10.
Doctor,
DCIS is
doc,
10.
DCIS.
Yes. So let's look at UD. This is UDH. But why did I put the relative risk associated with the lesion is A? I mean, A and B are different. Then this lesion is not UDH. I don't know.
Is associated with the lesions on the image. You said Doctor for the
Columnar searching is this is some kind of papillary something. There's prominent nucleolus. Could it be papillary DCIS? If it's papillary, then the answer should be C. No.
Is this atypical then? What do you see in atypical DCIS? Atypical Dr. Papillary, what do you see?
Usually looks like DCIS, but less than 2 millimeter. That's the only thing.
Is what?
The same thing as DCIS, but usually less than 2 millimeters.
Less than 2 millimeter.
Yeah. Anything that looks like DCIS but less than 2 millimeter is ADH. Now this
2
one,
millimeter, is it grossly?
no, on microscopy now you measure with a ruler. Do you normally do measurements under the ruler in where you sign out cases?
I didn't master that too. Some consultants do that. I really did not learn it.
All residents do it in my place. That's for resection case. If you have this breast DCIS, you have to measure sometimes. If you do frozen section and all those kind of things. But anyway, and then distance to margins, all those things, you have to learn how to do it. Now, this to me looks like papillary DCIS. Which one is
Okay.
I'm not
What do
sure.
you want us?
There's
What do
prominent.
you want us to do?
Now let's just test it and see. And I think it's very we have wasted enough time. Not wasted enough time. We have spent enough time. We didn't waste it deliberating.
I want us to set a target. So let's want to be finishing one question within 20 minutes. Yes, depth is important, but we need some level of breadth too.
I think the problem we have is not is certain time. I think the problem we have is if we are consistent. If yesterday we spent the time we're supposed to spend, we'll go far. I don't know.
What I know, I'm saying we should still have a goal for the time too, like 20 minutes or 25 minutes at most per one question.
Remember that some questions will be very fast, some questions will be very, very.
Yes, that's why I said 20 to 25.
Okay, let's see how it goes. We'll do our best. But I think in the whole, as the spirit leads, because sometimes we'll do our best. We'll do our best. So let's quickly look at it quickly and then stop it. Leave here. ADH, but why is this ADH? Okay, the cells appear monomorphic and the cells appear to have prominent nucleolus. They have cribriform and micropapillary architecture. This architecture is actually micropapillary. That's the thing. You know, what difference between papillary?
Polypopic population, low-grade cytologic features.
First of all, this thing is not UDH. Why it's not UDH is because it looks monomorphic. The cells have uniform size. Actually, I was not thinking of DCIS the more. But this case is not, since they didn't bring up DCIS, this case is not UDH. Why? Because it's monomorphic. Monomorphic means the cells look similar sizes. In UDH, there'll be the cell size will be polymorphic. The cells vary degree of size, some large cells, some tiny cells. And then this micropapillary, what the difference between papillary and micropapillary?
Fibrovascular core.
Yes, these are micropapillary.
Microbiome.
They have no fibrovascular core.
Microbiome doesn't have
Yeah,
true fibrovascular core.
yes, and these ones have prominent nucleoli. Can't you see? So this is more or less not in the territory for UH. So the scribiform, not really. A micropapillary architecture resembling low-grade DCIS. Partial involvement of ducts or limited extent, which distinguishes it from DCIS. What they're saying that some of the ducts were involved, like here. Maybe this place is involved, some other places maybe not involved. There's partial involvement of the duct. So rounded secondary lumina and rigid architecture is on foci. So rigid architecture is on foci. Okay. ADH is a proliferative breast disease. So if this were to be ADH, then the answer should be what? 4 to 5.
4 to 5.
Yes. Risk stratification. Here is the relative risk of invasive carcinoma of various tissues. Non-proliferative changes. Anything that is non-relative risk is 1. Usual ductal hyperplasia, we are right, 1.5 to 2.0. And A and B are the same thing. ADH is 4 to 5, so the answer will be D. DCIS is 8 to 10, LCIS is 8 to 10. So the
answer is A. Okay.
So the answer is D. The question is the relative risk of invasive carcinoma. The relative risk associated with non-atypical.
Okay.
Oh, wait.
This is hyperplasia, not carcinoma.
It's ADH, yes.
Yes, it's D. It's D.
But the relative risk associated with non-atypical proliferative disease.
You know what? Let's go and look their own response.
Yes, we'll look at it now, but I'm trying to figure it out before we look at it quickly, so that the relative risk of DCIS is 4 to 5. No. Okay, this is atypical, non-atypical. Okay, let's see. So say A is the correct answer because all these things don't make sense to me. But let's see.
Why would this be A? Is this
the reason why? So what they are saying?
Which is funny regarding
the question does nothing to do with the image. That's the problem. You don't need the question to answer. Yes, the image.
You don't need the image to answer it.
Yes, he said, which of the following statements regarding relative risk of developing an invasive carcinoma is true? It didn't make reference to the image. The image is actually an ADH image, right? It's an ADH image. Are you with me, sir?
Yes.
Even though it's an ADH image, you don't really need it to answer the question. So, but all these things doesn't make sense. Here, they did not tell us that.
Let's read their response. Let's quickly read it.
Okay, read their response.
Atypical microplasia. This is 4 to 5. Proliferative non-atypical epithelial hyperplasia. Fluorescence, okay, now it's 1.5 to school. 10 to 2.
So, what do you think? Are you done?
Okay, scroll up a little. It's okay.
Okay, you done reading?
For all of the described entity except Dr. Casimir, the list is primarily ipsilateral for Dr. carcinoma in situ. But
You done?
right,
Hmm?
the last part, the last paragraph, that's what I want to read.
Okay.
Okay, I'm done.
Okay. We'll quickly do the review. Okay, that's good. While we are waiting for it, let's go to this other question. You can start looking at this question. We may why I try to solve that. All the following statements regarding vascular lesions that occur in the breast and the associated region are true, except lefangsarcoma occurring in the arms of patients who have undergone modified radical mastectomy is also known as Stewart-Trevor syndrome. The median age of primary mammary angiosarcoma is the 30s and 40s, and survival related to grade, presence of numerous metastases, blood leaks, and necrosis. Benign vascular lesions include perilobular hemangioma, papillary endothelial hyperplasia, atypical vascular lesion, benign lymphomatous purple. Angiosarcoma in the skin of the breast after lumpectomy and radiation therapy is primarily high grade, but will be low grade. The image shown will not have been taken from
All of them are chronic
high
and
grade sarcoma.
actual effects. This one look like angiosarcoma. But
Okay.
let me read the other of the options. So you want us to answer the next question, number 12 now, right?
Okay, now we'll come back to this question. Now this one is ready. ADH is with micropapillary features is associated with relative risk of what? Of developing cancer.
Is ADH 45. Let's
Okay.
move on.
Uh,
45.
it's still business. So this one, we are still waiting for it. This one, what do you think is the answer of this one? You
12.
first,
Okay, let me look at it.
I'll give us only 30 seconds looking at it. Since we think we should be timing ourselves. 1 minute, maximum of 1 minute. After that, we will not have to wait for it. Otherwise, we'll miss out on a lot of important things. Actually, this is meant to be a study. Not just this study,
It,
it's a study something.
it
Okay.
should be both. We should, we are trying to fill in the gap in our knowledge.
Yeah.
So it's always good to know where we stand before we start now going for explanation.
Yeah. So
Uh-huh. The-
time up. Okay. So choose an answer quickly. I choose C based on the, but I don't,
True, except that's the issue now.
okay.
Edges of the screen or the best
This topic needs a lot of analysis. So be prepared because a lot of things I don't really understand it, and I would like to explore all the
And
things.
let me look at it. Let me try and answer it.
We have already
I
passed the
know I know A is correct. I know the first one is correct. The primary,
Okay,
He must have been taking edges.
what is the Treves syndrome?
That's the definition. The patient that has breast cancer, they now have maybe radiation to the arm for maybe the ancillary lymph nodes now. Then after that, the patient now developed lymphangiosarcoma.
Okay.
It's post-radiation condition. It's a sarcoma
Mm.
following radiation in patient with, you know, usually mastectomy.
Mm. Are you done?
Mm-hmm.
If it's
I guess
exam,
the skin of the breast after the radiation
more than
is
1 minute.
ideal, but maybe low. Okay, if I want to choose, I'll choose E. Okay, let's continue. So,
Which of the following lesions carries no increased risk of breast carcinoma compared to the general population?
mm, okay, other ones are radial sclerosis disease are proliferating non-atypical breast disease, atypical lobular aplasia. So those first two are what? Like 1.5 to 2.
Yes.
Then D, atypical lobular aplasia is, I think that one should be like 4 to 5. Okay, let's continue.
Yes. Hypocrite metaplasia. So number 3.
It's usually going to be better without atypical with series of developing 1.5 to 2.
Number
Okay.
4.
It's value of 4 to 5. Yeah. Total condition for 8 to 10.
Anything that has a TP already goes to
Yeah?
anything with a TP already goes to 4 to 5.
Yeah, 4 to 5.
This
Then if
year,
it is DCIS, 8 to 10. Or LCIS.
number
Okay, 6. Invasive, which of the following is the risk of basic cancer primary ipsilateral is DCIS.
this year
Every other one is
bilateral.
bilateral.
In this year, in 8ALH, LCIS, complex carcinoma,
This person is
CIS has ipsilateral risk. That means
which
it's
lesion is considered to have a area of 3 for carcinoma development. 3, 1.5 to 2. Complex fibroadenoma compared to simple fibroadenoma. Okay,
it's
within the first 10 years. 8C,
so
they read it.
the
Huh?
time frame during which proliferative lesions with or without the TPR present the highest risk in the first 10 years.
Yes.
And it decreases afterwards.
Yeah.
Uh, 9. That's why this size is treated with lumpectomy. Number 9.
It decreases by tutors after 10 years.
After 10 years, the risk decreases by 66%.
Which is bilateral increased cancer risk. Everyone, okay. Atypical lobular aplasia.
Yes, ALH or LCIS. And give you a bilateral cancer risk. 11.
1.5 to 2.
Number 12.
It's an families of breast cancer. Proliferative disease. Family history 8 to 10. But if it is that, yeah,
So once there's presence of family history, ALH and ADH bumps up to 8 to 10.
yeah,
13.
each of the following feature in about tissues will suggest that the, over the, of the, condition. 14. 15. 16. 17. 18. 19. 20. 21. 22. 23. 24. 25. 26. 27. 28. 29. 30. 31. 32. 33. 34. 35. 36. 37. 38. 39. 40. 41. 42. 43. 44. 45. 46. 47. 48. 49. 50. 51. 52. 53. 54. 55. 56. 57. 58. 59. 60. 61. 62. 63. 64. 65. 66. 67. 68. 69. 70. 71. 72. 73. 74. 75. 76. 77. 78. 79. 80. 81. 82. 83. 84. 85. 86. 87. 88. 89. 90. 91. 92. 93. 94. 95. 96. 97. 98. 99. 100. 101. 102. 103. 104. 105. 106. 107. 108. 109. 110. 111. 112. 113. 114. 115. 116. 117. 118. 119. 120. 121. 122. 123. 124. 125. 126. 127. 1
Irregular lumens with hyperchromatic cells at the tip. If you look at these cells, the cells at the tip are hyperchromatic compared to the rest. If you look at it.
Okay, irregular means hyperglycemic at tips. Okay.
More or less have irregular cells. Irregular bridges. The cells at the tip are hyperchromatic. Look at it.
Okay.
Here, to hyperchromatic cells at the tip. The base are not as chromatic as this place. Wow, that's very. So this ADH papillary pattern, especially, is the one that have this. Central papillomas, nipple location are classified under which category?
Papilloma, the proliferatory disease.
Non-proliferative disease. Peripheral papillomas of the breast are going to be proliferative. Central ones that are close to the nipple are called non-proliferative cystic diseases. They are very benign. They do not increase cancer risk at all. Then to present with apocrine metaplasia. I see a lot of apocrine metaplasia too. 15. What's the relative risk of non-proliferative cystic breast disease?
1.
1. Good. Let's come to this now. Question number 12. So how do you describe this lesion?
Is a neoplastic lesion, like a malignant neoplastic lesion, composed of anastomosis vascular channels lined by, what look like a typical epithelial cells.
I'll be back shortly. Don't get me quickly. Sorry, yeah, is it ready now? Sorry. I had to quickly get some water. Kind of lemon water, sorry. I was right. I followed the clue. Are you there?
Yeah.
So the answer is C. Couldn't have been taken from a high-grade sarcoma. So you are right. So option A is Stewart-Traver syndrome. Stewart-Traver syndrome is a well-known entity describing lymphangiosarcoma in lymphadematous arms post-mastectomy. So somebody has modified radical mastectomy, and after that develops lymphadematous arms. That's Stewart-Travis syndrome.
Usually you okay, but most of it is associated. Yeah,
Associated with
it's
what?
associated with radiation therapy.
Okay. Now, benign vascular lesions include perilobular hemangioma, papillary endothelial hyperplasia, typical vascular lesion, benign lymphangioma papule. Do you know how all these things look like? I want to be sure it is the answer. Let's be sure. Okay, it's the answer. Now, do you know how these things look like?
Papillary endothelial hyperplasia. I have an idea how that look like.
Let me quickly evaluate them quickly. So the first one is perilobular hemangioma. Perilobular hemangioma. Sorry. Hemangioma pictures.
Histology picture.
So
Perilobular.
there are rare vascular lesions of the breast, typically found in premenopausal women, often detected incidentally on imaging or biopsy. So they're usually well circumscribed, like here you see it well circumscribed. In the interlobular stroma, there's stroma around it, composed of capillary-sized spaces. The capillaries, a lot of capillaries. Capillary-sized spaces arranged around the terminal ductal lobular units. So that's why it's called these are lobules.
Papillary cells focus. I don't know.
Yes, endothelial cells are bland without atypical or mitotic activities. It's perilobular hemangioma. What's the IHC? CD31, CD34, and egg. These are all used to look for endothelial matters. They'll be negative. The negative for HHV8 markers. HHV8 is for Kaposi sarcoma. Hemangioma variants. Okay, very good. It's important to distinguish it from low-grade angiosarcoma and vascular involvement by carcinoma. They have benign behavior, no treatment required beyond diagnosis. Now, the next one is papillary endothelial hyperplasia, Marson's tumor. Let's get histology pictures of this. It's a reactive proliferation of endothelial cells occurring within a vascular space, often following thrombosis. It's a well circumscribed lesion of papillary fronts. It occurs due to, let's see, can you hear me? Can occur anywhere in the body, skin, soft tissue, intracranial vessels. It occurs within a vascular space, following thrombosis. Histologically, it's a well circumscribed lesion composed of papillary fronts. You can see papillary fronts. That's why there's papillary in the name, papillary endothelial hyperplasia. Papillary fronts of what? Fibrin or connective tissue. And then these papillary fronts
lined by benign epithelial cells.
By benign endothelial cells. So it's going to be papillary fronts of fibrin, connective tissue lined by benign endothelial cells. They occur within pre-existing vessels or organized thrombus. That means that thrombus, and if there's thrombus, the thrombus contains fibrin, right? Then they kind of fragment into multiple fronts that are lined by endothelial cells. This probably would have been an initial thrombus made up of fibrin network. The endothelial cells will now form around them to form papillary fronts, papillary fronts of fibrin or connective tissue, like endothelial cells. They occur within an existing pre-existing vessel or organized thrombus. They lack nuclear atypia or increased magnetic activity. There can be variable number of inflammatory cells, all that IHC markers, endothelial cell markers, of course, CD31, CD34, and egg can be used also, egg. But here, there's about factor 8 related antigen. This also is also used to look for endothelial markers. You know, factor 8 is found in endothelial cells too that can sometimes be released from biopalette bodies alongside with from liberal factor. So factor 8 related antigen, CD31, CD34, KI67 will be low. The potential diagnosis is angiosarcoma, but angiosarcoma will not be well circumscribed and it will not occur, within the thrombus, and it will be atypical. Intravascular papillary endothelial hyperplasia is purely benign and reactive. Clinical lesion may be excised to rule out malignancy. It's important not to misdiagnose as angiosarcoma. These are more pictures. I think we've seen enough pictures already. You can see these papillary fronts of fibrin as papillary. What's the name of the entity again?
Papillary endothelial hyperplasia.
Papillary endothelial hyperplasia. Very good. Okay. It's also called, what's another name for it?
Masson's tumor.
Masson's tumor. Then the next one is atypical vascular lesion or benign lymphangiomatosis papule. Atypical vascular lesion or benign lymphangiomatosis papule. What was the first one we looked at? Do you remember the name?
Is it not perilobular hemangioma?
Yes, it's perilobular hemangioma. The next one is papillary endothelial hyperplasia or Masson's tumor. So this one, atypical vascular lesion of benign lymphangiomatosis papule, it occurs mostly in the skin following radiation therapy for breast cancer, for instance. It's usually confined to the dermis. On histology, you see multiple irregular anastomosis vascular channels. Multiple, it's not very clear. Yeah, these are multiple vascular channels. They are irregular. This is a vascular channel, vascular channel, vascular channel, vascular channel. They are irregular. Are they anastomosis? I'm not sure. And they are lined by bland yes, here the irregular vascular channels. Anastomosis are lined by bland endothelial cells. They are found in the superficial dermis and may involve the epidermis, no infiltrative growth pattern into deep tissues. They may make early angiosarcoma, but they lack atypia or mitosis. They're usually positive for D240 and see them in the upper dermis, irregularly shaped vascular lesion, vascular channels, lined by bland epithelial cells, irregularly anastomosis. What's the name? What's the name, sir?
Hello. Irregular anastomosis vascular channel line of bland epithelial cell, superficial damage.
So what's your name?
I didn't get you.
What's the name of the entity?
Atypical vascular lesion. If one is not careful, one might mistake for angiosarcoma. The only thing is that, and which other lesion can one mistake for? Kaposi sarcoma. It's just that this one is benign.
Yes. The history will be, it will have the Kaposi sarcoma will be positive for HHV, remember.
Mm.
But this one is this one is that the lesion is benign. Yes, lesion is benign here. And not only that, I already said something which I've forgotten. It occurs, the history also is important. It occurs following radiation therapy. It occurs following radiation therapy. So, what molecular marker helps to rule out radiation-associated angiosarcoma in this entity?
You say my C amplification.
My cell amplification will usually have associated with radiation-induced, radiation-associated angiosarcoma. I just have my cell amplification. Here 67 will be low. All of these will be positive for lymphatic mark, for endothelial markers like CD31, CD34, maybe egg. The other one was positive for, there's a special marker that we found in the endothelial factor 8 related antigen. We found that in endothelial hyperplasia, papillary endothelial hyperplasia. This benign lymphangiomatoous papule, atypical vascular lesion. Okay. Okay, let's look at this. CD. Now, do you know the markers D240?
Is the lymphatic marker.
Yes, it's also for mesothelial cells, mesothelioma, anything mesothelial cells. D240 positive is a marker too for this thing.
Mesothelioma.
Yes, the mesothelial markers. Okay, now clinical relevance presents as small red papules in irradiated fields. It's important to distinguish it from radiation-induced angiosarcoma, which is aggressive. Surveillance is recommended, but typically no aggressive treatments are needed. So these three entities, we've looked at them, and this one can be confused with angiosarcoma. This one is radiation-induced angiosarcoma, but it's MYC negative. This is low-grade angiosarcoma. So we are done with this. So I think it was worth it. So when we look, question say benign vascular lesions include perilobular hemangioma. That's correct. Papillary endothelial hyperplasia. That's correct. Atypical vascular lesion. What's another name for the atypical vascular lesion?
Benign lymphangiomatoous
Benign
papule.
papule. Good. The image shown could not have been taken from high-grade angiosarcoma.
That's false.
As for because it's actually a high-grade. I don't know why there's no text for this. Why? This is high-grade angiosarcoma. So the image features is compatible with high-grade angiosarcoma, which has irregular anastomosing vascular channels. The channels are irregular and they are lined by atypical endothelial cells with nuclear pleomorphism, hyperchromasia, and hemorrhagic areas. Therefore, it is correct to state that this image does not represent high-grade angiosarcoma. If you look at this image, there are some vascular leaks. So let's quickly high-grade angiosarcoma. What do you know about high-grade? We'll come to the teaching point later. High-grade angiosarcoma. So what are the features of angiosarcoma? High-grade angiosarcoma.
Maybe the degree of ATP of the cells.
Yes. An irregularity. Hello, sir, are you with me?
I'm with you.
The vascular channels will be irregular, contain vascular tract mix. Understand? So let's see if we can get more pictures of it, and we'll see more pictures of this. Histology pictures. The pictures. High-grade angiosarcoma. Let's see if we can get histology pictures of it. So while we're waiting for that, This one, the median age for primary mammary angiosarcoma is the 30s and 40s, and survival is related to grade, presence of numerous mitosis, blood leaks, and necrosis. True or false?
Okay. To the group. Mitosis, blood leaks, necrosis, all those
Yeah, these are
is
features.
related to the grades.
Yes. You used to grade it, the numbers, the frequency of mitosis, the presence of blood leaks, presence of necrosis, all these are used to grade this. This is actually a true statement. Primary mammary angiosarcoma is usually in the 30s and 40s. We're going to see that look at our this. Let's look at this again. You can see significant, this is it. Irregularly shaped vascular channels and anastomoting one another, hyperchromasia. If you look at images of mitotic figures, this doesn't look benign. This doesn't look benign. And what will be the markers for it? Wow, this doesn't look benign at all.
34, 31, 34, HHV8.
There will be high KS 67. I think there should be. Histology features. Let's get at histology and IHC features. So there'll be no, our class ends in about 45 minutes time, so there's no break for today. So let's come back to here. Okay, I think we've seen until you know. So IHCs for angiosarcoma. Pleomorphic cells, mitotic activity, vascular channels with hemorrhage and necrosis, blood leaks. There's epithelial variant, there's a spindle cell variant, and then CD31 will be strong, and if you CD34, egg will be there. Poroplanin. What's another name for D240?
Poroplanin, D240.
It's going to be seen more in lymphangiosarcoma. You know that it's for lymphatic channel. It's a marker for lymphatic channel vasculature. Now, that's Stevens. What about that syndrome again? Stewart-Treves syndrome is lymphangiosarcoma, right?
Stewart-Treves syndrome, yes.
Lymphangiosarcoma, yes. Stewart-Treves syndrome. Do you know we didn't even look at a picture of lymphangiosarcoma? Can you describe how a lymphangiosarcoma will appear?
I'm not sure.
So this, one of the things is that this will have high Ki67. This angiosarcoma. Must have high Ki67. They will have poroplanin. If it's lymphangiosarcoma, poroplanin will be positive. They will have factor VIII related antigen. These are all markers for endothelia. Endothelial markers are CD31, CD34, egg, factor VIII related antigen. By the way, let's quickly look at this syndrome. And let's look at lymphangiosarcoma.
Maybe you should just go ahead and look at lymphangiosarcoma. We already know the syndrome.
Yes, that's what I want to do now. Lymphangiosarcoma histology pictures. Histology pictures. Sarcoma histology pictures. I want to make a video of all the entities in pathology using these past questions, like basic entities. So all these videos I'm recording it, I'm going to upload it on YouTube and send to you. You can always watch it. I'm titling this one breast pathology. If you can watch before we finish, it may be up to 24 hours or 30, I don't know. But if you can watch it all, it will give you a refreshing every time. Maybe like Kaplan videos. every topic will have our own videos on it, but it's unlisted videos. We can't share it online because we don't have rights to share it online. Okay, while you are wasting time here, let's quickly review our points here. So the last point was actually about angiosarcoma in the skin of the breast after lumpectomy and radiation therapy is primarily high grade, but may be low grade. That's actually a true statement. What's the name of the angiosarcoma that occurs after radiation? So you remember?
Hmm?
What's the name of the angiosarcoma
That
that
is the Stewart-Trevor syndrome.
no. That, no,
Liver,
that's liposarcoma. The name of the
uh,
angiosarcoma that occurs post radiation, what is it called?
what's that?
There's an angiosarcoma that occurs post radiation. It's called post radiation angiosarcoma. You remember?
Okay.
We saw it earlier. What did we see about the post? What did we see about it earlier? You remember?
No, what's it?
We said something about it, about post radiation like angiosarcoma, where we said we differentiate it from. It resembles this a vascular malformation, vascular lesion. They say this entity here. What about this entity? Atypical vascular lesion. It's one of the differentials of atypical vascular lesion or benign lymphangioma papule. But benign lymphangioma papule will have bland cells. The other one has MYC amplification. Remember, we see that it
Yeah.
has YC amplification. So just as a quick reminder, how would the histology of perilobular hemangioma appear like?
Capillary size cells
Mm,
in the interlobular stroma
yeah, surrounding.
surrounding
Yeah.
the lobus.
Mm. Okay, sir. So this is hydrogen angiosarcoma. So these are all the features of hydrogen angiosarcoma. No, this is lepangiosarcoma. Sorry, lepangiosarcoma.
Somebody's calling me. Let me quickly pick it. Let me quickly pick this.
Okay, sir.
I want to quickly pick a call, please.
No problem, sir. Go ahead, please.
I've missed the call. I'll call the person later. Let's go.
Okay, just a minute, please. I'm trying to. So, what are the histologic features of lymphangiosarcoma? That's what we see. This is lymphangiosarcoma, coconut lymphangiosarcoma. Sorry, just a minute, please. So, what will be the histologic features of lymphangiosarcoma? I think it will be similar to angiosarcoma, right? Right?
Similar feature, but the issue will be very important.
Yes. The history of Stewart-Trevor syndrome again, right?
Mm.
Again, I keep forgetting that name. Stewart-Trevor syndrome. Okay, good. So let's go to it's still fixing here. Lymphangiosarcoma. So lymphangiosarcoma we have endothelial cell ATPR, some solid areas. There'll be some solid areas, some hemorrhage and necrosis. Sorry. Some solid areas, hemorrhage and necrosis. What IHC marker will make you think of lymphangiosarcoma? What IHC marker is?
P240.
Yes, or proplanin, specific for lymphatic markers. Okay, good. That's okay. I think we are done. While we are waiting for this guy here, let's go to the next question.
Let's read through the points.
Okay,
The
good.
teaching point.
Okay, yes. The image depicts a low-grade angiosarcoma. Most high-grade angiosarcomas also have areas of low-grade angiosarcoma, which is why for appropriate grading. Numerous benign vascular lesions may be seen in the breast. Angiolipomas are delimited lesions characterized by increased vascularity toward the outer capsule without internal stimulating channels. I can't hear you. The network is cracking. Can't hear you.
Unless you want to give company. Jonah, so that will be fast. You may not. Hello, Jonah.
I hear you.
You don't need to read this one out unless you want to give comments.
Okay.
I said this teaching, but you don't need
Yeah,
to read
I'm
it.
not reading it out again. But do you have this thing? I want to see something. Do you have network is bad from your side? Let me know when you finish reading. Are you done? Hello, can you hear me, sir? Hello.
Yeah.
I couldn't hear you again. I said, can
Okay.
you sorry? Can you know what? Can you know what I'm not saying? I can't even hear you. I log out and log in again. I can't hear you. Hello. Okay.
Okay, I'm back, Jonah.
Oh, I can hear you better now.
Uh,
Okay, so are you done reading?
yeah.
Let's quickly review our slides quickly. Which feature is most characteristic of low-grade angiosarcoma of the breast?
B.
B, yes. So internastomosing vascular channels with mild atypia. So this is the most characteristic feature. High magnetic activity is more with high-grade angiosarcoma. Abundant necrosis will be high-grade angiosarcoma. Prominent vascular popular architecture. Okay. So low-grade angiosarcoma typically shows interanastomosing vascular channels with only mild endothelial atypia, making it challenging to diagnose. So if the vascular channels are anastomosing, it makes it challenging. So it resembles low-grade angiosarcoma. What entity can mimic low-grade angiosarcoma that we saw earlier today?
Avascular anastomosis mission.
Atypical
Atypical. Benign lymphangiomatosis.
papule. Yeah, benign lymphangiomatosis papule. Where is it again? Can't even see it here. It should be here now.
Don't worry, let's go on.
Okay, I seen it. It's called benign. It's the vascular lesion, benign lymphangiomatosis papule. Good. Yes, sir. So they have intravascular channel with only mild endothelial atypia, making it. You know what? Which benign vascular lesion is most associated with microthrombi and lacks internastomosing channels?
Papillary endothelial aplasia.
That's microthrombi.
Okay.
But there's another entity we have not looked at. It's called angiolipoma. You know angiolipoma now. It's associated with microthrombi. You know angiolipoma, just lipoma.
More in kidney, is in kidney. They say it's in kidney.
And that's angiomyolipoma.
Okay.
Let me show pictures of angiolipoma. Angiolipoma pictures.
Histology.
So angiolipomas have increased vascularity near the outer capsule and are associated with scattered microthrombi without anastomosing vascular channels. Here they mention something about angiolipomas. Where is it? There are delimited lesions. Okay, let's see if we can get it. Only one picture. No, it's 6. Okay. This angiolipoma, lipoma, mature adipose tissue, muscles, no, vessels and fat. It doesn't make sense to me. This angiomyolipoma, there's muscle here, that's why. Most of this angiomyolipoma. Congested blood vessels, adipocytes, muscles. So angiolipomas. Now, question number 3. Primary mammary
Let me read that question 2 again. Have increased near the outer capsule and associated with scattered microthrombi without anastomosing vascular channel. Okay, let's continue.
Okay. And it's near the capsule of the lesion is where you're going to see a lot of the vessels. That's what they're saying. But they're not anastomosing. Anastomosing is mainly associated with sarcoma. When you start seeing anastomosing, especially for low-grade sarcoma, that's associated with sarcoma. Primary mammary angiosarcoma typically occurs in which age group?
30 to 40, young age groups.
29 to 42, depending on the tumor grade. Question number 4.
76%.
Primary 76%. Grade 2 is 70%. Grade 3 is 15 months. And a 15% 5-year survival. So grade 3 is very dangerous. So the worst grade is probably grade 3. for the thank you for the what's the name of this thing now? For the angiosarcoma. Wow. Did you get it?
Yeah, I got it.
Okay.
Let's go.
Question number 5.
A. Stewart-Cherry syndrome.
About Trevor's syndrome, yes. Post-mastectomy lymphangiosarcoma of the arm. What marker will you use for it? IHC.
CD 31, 34, ERG.
Which one is specific for lymphangiosarcoma?
B2 14.
Yes. Or
Podo something.
planning.
Hmm?
Planning.
Podo planning. Okay.
All the other ones you mentioned are endothelial markers. They're not really specific, but the endothelial marker can be found in angiosarcoma as well. Question number 6.
Intro is good. Intravascular location and bland cytology.
Yes, intravascular location.
Pre-existing vessel.
Yeah, pre-existing vessels and especially thrombi, because the endothelium will kind of line the thrombi, fibrin, and all that. Question number 7.
Which lesion occurs within several years? Okay, within several years after radiation, post-radiation angiosarcoma.
Yes, very good. And it's malignant.
Um,
8.
it is an atypical vascular lesion.
Yes, what's the name for atypical vascular lesion?
Capacitated lymphatic space and lymph follicles. Wow.
Benign lymphangioma papule. They can be,
Dilated lymphatic spaces. I may have associated lymph follicle.
but
Did you check that one before?
what's the difference between it and angiosarcoma, post-radiation angiosarcoma? H and E.
Angiosarcoma.
Mm. You have anastomosis.
Eh?
Low-grade angiosarcomas will have anastomosin channels.
Yeah.
Yes, very good. Okay. And that's what's another name for mass. What is Masson's tumor? Remember.
That's is it this one? Atypical vascular lesions.
Papillary endothelial hyperplasia, remember.
Okay, papillary endothelial hyperplasia. That's one associated with fibrin.
Yes, fibrinous papillary.
Thrombosis.
Question number 9.
That's D.
They are treated with lymphoid follicles. Okay. Question number 10.
D 0.21%. That's a figure to remember.
Okay. Number 11.
Okay, the first question was the type of tissue. Adipose. Excessive fasciculation dissecting adipose tissue.
Low-grade angiosarcoma. Let's quickly see some pictures of low-grade angiosarcoma. Low-grade angiosarcoma. So let's say that let's even be sure. This is angiosarcoma, not low-grade angiosarcoma. But the vascular channel, here, you see it, this is what I'm thinking about. Vascular channels dissecting through adipose tissue. So can you see it?
Okay, yeah.
The low-grade angiosarcoma, they have vascular channels dissecting through adipose tissue. That's the best. So look at low-grade angiosarcoma typically shows excessive vascular channels dissecting adipose tissue. Very nice. Papillary endothelial hyperplasia most likely represents what?
Abnormal thrombus organization.
Yes, because it forms in an organized thrombus material within vessels. What is the approximate disease-free survival time for grade 3 angiosarcoma?
15 months.
15 months. So bad. Which of the following is true regarding post-radiation angiosarcoma?
No need post radiation. The vaccine takes a period of several years.
Yes, it's just usually
Within the first 10 years.
after only a few years. They didn't mention the number of duration, but after a few years. Which number 15?
Which of the following statement about primary angiosarcoma breast is correct? It's occur in elderly women. C. Low grade may present in high grades, so sampling is important.
The low grade areas will be present coexisting with high grades. So the high grade and intermediate grade areas. So there's need for thorough sampling. So that's the need for this. That's the importance of this question. Sometime in angiosarcoma, if you see low grade areas, you want to grade it grade 1, grade 2, grade 3. Thoroughly sample it. Because if there's grade 3, the survival rate is low, right? So it needs thorough sampling. Well, so angiosarcoma is a very bad disease like this. Wow. As well. Stevens. One more time, look at the syndrome. Stewart syndrome. Stewart-Travis.
Stewart-Travis.
Stewart-Travis syndrome. What is your answer? I'll choose E.
Wait. A letter which realization. Okay.
Okay, are you ready?
Yeah. E is the answer. The one that is correct.
Yeah, well, because if you can use it, is the correct answer. You already went over this multiple times. Right. So let's quickly look at this one is going to be fast. So we'll just quickly look at 15 points. And then we are done. Okay, just a minute, please. Sorry. Next question. Now, question number 1. Gene expression profiling in breast cancer has led to which important realization?
Proven the system to exist with unique molecular correlates. Breast cancer is heterogeneous, composed of multiple distinct subtypes with unique prognostic and therapeutic implication.
Yes, breast cancer is heterogeneous. So it's not just the same kind of cancer. That's what it helps us to realize. Before if a breast cancer, no, it's heterogeneous and it's composed of multiple distinct molecular subtypes with unique prognostic and therapeutic implications. Yes, here too, different kind of implications for therapy too. Which of the following is considered a key component for breast cancer classification according to gene expression profiling?
Proliferation, K67.
Yes, Ki67, ERPR, HER2, Ki67, genomic expression profiling. Gene expression profiling shows that prognosis depends on molecular profile in a manner independent of what?
Stage.
So the prognosis as per gene profiling is independent of the stage of the tumor. So it depends on whether HER2 new positive, whether it is Ki67, whether it's lumina A, lumina B. So that's what determines prognosis based on genomic profiling, not just staging. Which subtype of breast cancer is defined by high expression of estrogen-related genes?
Nominal type.
Yeah, luminal type, not the basal-like type, not the HER2 enriched type. Which subtype, which two subtypes are commonly described as opposite ends of the luminal spectrum?
Normal life. Which one is normal life?
Opposite ends of the luminal spectrum. That is, lumina A and B are opposite ends of the luminal breast spectral spectrum. Lumina A, ER positive, PR positive, while lumina B and HER2 negative, while lumina B is ER, PRO negative or low with HER2 positive or negative value with HER2 variable, right?
Okay, yeah.
Which subtype is debated and possibly reflects tumors in rich tumor?
Tumors rich in stroma. Normal life.
Normal like, and that's due to what? Sampling, remember?
Yeah.
Yes,
Tumors rich in stroma.
there's a reason that
Something.
sampling we take, it looks so much normal stroma in between. The poor prognosis molecular apocrine type is typically characterized by which receptor profile? The molecular mm, we talk about apocrine carcinoma, molecular apocrine carcinoma.
Yeah, that's androgen receptor positivity.
Yes, ER negative, androgen receptor positive. Usually, the luminal breast cancers will be both ER positive and AR positive, lumina A. But this one will be ER negative and AR positive. Molecular apocrine cancers are also gene receptor negative or gene receptor positive. Do you know more about this molecular apocrine cancer, breast cancer?
No.
Let's see if we can look at this entity more. Let's explain it quickly. We'll not take time. It may just come out in the exam. I'll be like, oh, we saw it, but we didn't dive deeper. Explain this entity more. So, molecular epicurine type is a rare subtype of breast cancer that is primarily defined by molecularly rather than histologically. It was first characterized in gene expression studies where tumors showed apocrine-like features, but did not express the estrogen receptor, which is commonly positive in most breast cancers. Despite being ER negative, these cancers demonstrate a high expression of androgen receptors, a hormone receptor traditionally associated with prostate and male physiology, but also present in some breast cancers. So this is a woman having androgen receptor, of course. So ER negative, PR negative, HER2 new variable, negative or low expression, androgen receptor positive. So it's triple negative sometimes with androgen receptor positive. Molecular apocrine tumors tend to have worse prognosis, typically compared to typical hormone receptor positive cancers, because oestrogen cannot be used. Since it's AR driven, androgen receptor targets are using like enzalutamide for these tumors. They can look like hormone receptor positive cancers due to apocrine morphology. They have large eosinophilic prominent nucleoli, but the molecular signature is distinct. So
Okay. It's more of a molecular diagnosis. You have
Diagnosis.
cell histology, you have apocalypse features,
Yeah.
but ER is positive.
Yes. AR is positive.
It's negative.
AR is negative. AR is positive. So it's like a normal tumor with apocrine features. Then when you do molecular profiling, it appears like triple negative, but AR is positive. But if you don't do AR, you won't even know. So
Yeah.
I see. Now, prognostic gene signatures in breast cancer are primarily driven by expression of genes associated with what?
Proliferation.
Expression of proliferation-related genes drives most prognostic signatures. So KI67, I don't understand. What does this mean? Do you understand? I guess this is about KI67, but let's see.
The degree of proliferation also may show at the degree of aggressiveness of the student.
Yeah, I agree with you.
And the prognosis.
Prognostic gene signatures are panels of genes which are expressed, which expression levels are analyzed collectively to predict the likelihood of cancer recurrence, progression, patient survival. Examples of clinically validated gene signatures include oncotype DX, mama print, prosigma.
Okay, sorry, let me see. Example of clinically validated signature assets. Mama print, Okuta DS, Endopredict, PAN 50.
I think these are analyzers, assays used to analyze the proliferation activity of breast cancer tumors. KI67 is the one we use. I just say KI67 is most breast cancer prognostic gene signatures are primarily driven by the expression of proliferation-related genes. So KI67 is not the only proliferation-related gene, right?
Okay, yeah.
There's OKE, there's MYBL2, there's CCNB1, but yeah, KI67 is the prominent one we know. So it can predict tumors' biological aggressiveness and recurrence risk. Why do estrogen receptor negative breast cancers have poor prognosis according to gene expression profiling? Question number 9. Why?
High proliferation.
Yes,
The positive one have low KI67.
yeah. Remember that the lumina A, which has AR positive, has low KI67, while lumina B, which is AR negative, has high proliferation, right? Question number 10. That means this is kind of important to breast pathologists for us to have seen this genomic expression profiling again and again. Second generation prognostic signatures incorporate which additional features beside proliferation? Immune response signatures. So there's immune response. So apart from KI67, they're not incorporating ability to immune response, ability of the body to immune system to respond to it or something. I don't know how that operates. Question number, let me see. Let's look at the text. Look at what I said here. Rare estrogen receptor negative, low proliferating tumors show only a limited prognostic difference. Although second generation prognostic signatures use immune response signatures, which correlate with level of inflammation associated with the tumor to show better prognosis in association with high immune response. The number of relapses remain too high to avoid chemotherapy. Do you understand?
Okay. So for the second this immune response signatures.
So better prognosis, if a tumor has a lot of immune response, it's also used these days as part of prognostication.
Okay, yeah.
Better immune response. I mean, there's better prognosis. However, you still have to give chemotherapy. Why? Because if you depend on the immune system alone, thinking the immune system will clear it, there may still be relapse in this patient. Despite improvements, why can't second generation signatures alone avoid chemotherapy?
Relapse rate too high. High
Yeah.
relapse rates, common this.
Immune therapy remains necessary even when immune signatures predict better outcomes. Response to chemotherapy is best predicted by what?
Proliferation rates.
Yes. They had the proliferation rates, the better the response to chemotherapy. That rapidly multiplying cells are good for tumor targets. Which set of conventional markers still provide strong prognostic value alongside gene profiling?
PIR2, TI67B.
Yes, those are for IHC. Molecular data is like fish. IHC will give you, equivalence. Venice et al. Demonstrated that randomly selected large gene sets often correlate with outcome. Random signatures often predict outcome because of the pervasive impact of proliferation of genes. I don't know that's in. Why does capturing members of proliferation cassettes happen easily in gene signatures?
How does capturing members of the recent cassettes elements alongside the cassette increase the likelihood of the random selection include in its component the provision performance.
Okay. Is it clear? I don't think this is clear to me. I don't think it matters.
It's not clear to me too.
I don't think it matters. Look at it. You see, Bennett et al. Observed that 90% of all randomly generated signatures containing more than 100 genes relate. Let me please see if you can explore it just very fast and we'll be done. We'll not take them. So gene expression signature. In cancer biology, especially in the studies of breast cancer, scientists often try to find patterns in gene activity that can predict how aggressive a tumor is or how likely it is to respond to treatment. These patterns are called gene expression signatures. So gene expression signature just means patterns of gene that shows if this tumor is going to respond to treatment or not. Think of signature as a list of genes whose activity, whether they are turned on or turned off, is associated with a certain outcome, like patient survival. So if some genes are turned on, there's a way the patient will behave. If some genes are turned off, there's a way the cancer will behave. So whatever is turned on or turned off determines how the patient's cancer will behave. So those are the signature just refers to a set of patterns that tells you how this particular cancer will behave. So some signatures may show more these particular genes are turned on. So the other signatures mean the other particular genes are turned on. So Venet and colleagues wanted to test how meaningful these gene signatures really are. To do this, they performed a very simple but clever experiment. They created random gene signatures, meaning they randomly picked genes from the human genome without using any biological reasoning or hypothesis. Each random signature included more than 100 genes. Then they tested how well these random signatures could predict breast cancer outcomes, such as survival or disease recurrence. The surprising finding, 90% of random signatures worked. Here's the big surprise. About 90% of these randomly picked signatures were statistically correlated with patient outcomes. This means that even when there was no biological reasoning behind choosing the genes, the signature still looked like it could predict which patients had better or worse outcomes. The result is very counterintuitive. You expect that only gene sets, choosing based on careful biological understanding, will show a strong association. Why did this happen? Enter the proliferation cassette. To explain this strange result, the researchers looked deeper. They found on something called the proliferation cassette. Here's what you need to know. The proliferation cassette is a large group of genes that are involved in cell division and growth. In breast cancer, tumors that are growing rapidly, high proliferation, tend to have worse outcomes because proliferation cassettes includes so many genes, and because random signatures were also large. Most random signatures ended up including at least a few proliferation-related genes by chance. This is likely like random sampling, picking up 100 words from a dictionary and almost always including a few medical terms, just because the medical section is so large and influential. Even so, random gene sets often looked predictive, not because they were truly special, but because they accidentally included some of the most important predictors of cancer outcome, like proliferation-related genes. The caution, don't overinterpret prognostic signatures. Here's the takeaway. Just because a gene shows up in a signature that correlates with cancer outcome does not automatically mean that that gene has a real meaningful role in cancer biology. The gene might be along for the ride, statistically speaking. It could be in the signature simply because the signature is large and overlaps with the high impact proliferation genes. Final thought, why this matters. If I expect, are you still there? You're still, sorry.
I'm there. I'm reading actually.
Okay.
So we can go back to the question. What
Sorry.
does Hector find?
Why does capturing genes or proliferation cases happen easily in
What
genes?
is that question on Hector? The 14.
Number 15.
14, the one that led us to go and be looking for
Yes.
the randomly selected lightning set often correlates with outcome.
Yes. We agree.
Yeah.
Yeah. So the thing was that they were selecting random genes. Unfortunately, those will always pick up some proliferation genes, like KI67. So the major thing was just this proliferation cassettes that was actually influencing all these random set of genes that they were picking up. So, just having a set of genetic signatures, saying this particular genomic expression pattern worsens cancer or makes cancer better doesn't really make sense, because randomly those gene expression signatures may contain KI67 or other proliferation markers, which are the main thing predicting it, not just this set of genes. It's a complex something. So it just tells us that genetic signatures are not very, very helpful in telling about prognosis as well as proliferation indexes. I don't know, but that's all. Okay.
So we can
go on in recess.
come back in 2 hours time or when?
Okay, no problem. We'll come back in about 2 hours, as you said. Our next questions will be, let me see, Ella's, Elston Ellis modification of Bloom-Richardson grading scheme.
That's what's it called? Nottingham building.
No, no, Nottingham grading. I don't even understand. I don't even know this kind of grading. But we're going to study it. Then we're going to study secretary carcinoma that you have been mentioning so much. Then we're going to study DCIS in details. Then we're going to study papilloma, papillary lesions of the breast. Then remember this uncle type mama print. Where did we see it before? If you get up to number 20, remember uncle type mama print, sir?
Yes.
Those were examples of what?
Validation, maybe to validate proliferation. So
Yes. And we just bypassed it thinking it was not important. Mama prints, uncle type. These are there were validated systems for measuring cancer proliferation. KI67 is one of them too. It's one of the things they measure. Since I mean, genomic medicine is actually taking over a lot of pathology. Do you agree?
yeah,
Okay.
you cannot replace H and E, but
You
it
can,
always
yeah.
makes things clearer.
Yes, and is the way precision medicine is what they are doing. And that's what we call precision medicine now, right? So we can just tell somebody that has breast cancer. We have to determine what kind of biological breast cancer do you have so that we can target the person's breast cancer more conservatively and more specifically. Do you understand, sir? That's why they are testing us on all these things. Okay, thank you, sir.
You're welcome.
2 hours time, sir.
We'll see later.
Okay, sir.
Yeah. So we end it for now.
Yes, I'm off to end the meeting now. Yes.